Sudo. Buenos dias. Good day from Miami Beach, home of Neurosurgical TV. Today we have the honor of starting a new channel, Neurointerventional Radiology, with noted educator Luis Ibor Lopez from Madrid, Spain. I had the pleasure of going to visit Dr. Ibor in Madrid. It was quite an experience, a true cultural experience. And today he was able to obtain the services of Jacques Moret, and I'll let Bernardo introduce him. Welcome, Bernardo. Bernardo is a neurosurgeon from Mexico.
Thank you very much.
Go ahead. Go ahead.
All right. Thank you very much. Welcome to the new round table of neurointerventional radiology. Let me say some words. Neurointerventional radiology transforms lives. Today we are not just to discuss techniques, but to save the future of patient care. It is an honor to begin the gathering dedicated to analyze and highlight significant cases in neurointerventional radiology. Together we will share knowledge, discuss strategies, and explore new perspectives in the treatment of complex aneurysms. I am Dr. Reinaldo from Mexico, and we have the honor to hear from Monsieur Professor Jacques Moret, Chairman of the Interventional Neuroradiology of June University Hospital, Paris, France. Professor is a leading figure in the development of advanced techniques for treating cerebral aneurysm and another vascular pathologies. His impressive career, including his tenure as professor of radiology at the Baylor College of Medicine in Houston, USA, as well as he had a vital role in training numerous specialists in neuroradiology. All right, we commence with the Professor Jacques Moret. Welcome and bienvenue, Monsieur Professor.
Okay, good morning, good evening, good afternoon. I don't know where you are listening from. I'm happy to participate to this conference. My friend Luis Lopez asked me to share with you some experience about the treatment of what he calls and what has been called the giant partially thrombosed and serpentine aneurysm. Honestly, it's not an easy topic, but I will try to do my best to share with you some experience and some thinking about this concern, which is really a big concern. Let me try to see if I can share with you. Okay. Okay. Can you see my?
Not yet. Not yet.
Not yet?
Not yet. No, just first button, show, share, the first button.
Yeah, this is what I did, but...
Okay, no, it's not sharing. Okay, try again.
Okay.
Yes, okay, it's coming.
But do you see it full screen?
I believe so. I'm not sure.
It's okay.
What does it look like to you? Okay, go ahead, go forward. Let's see.
How is it? Is it full screen for you?
Yeah, it looks good.
Okay.
Looks good.
Okay, so what do you see? You see a nice flower?
See a beautiful flower.
Okay. So this is just a gift from my garden. Okay. Okay, so let's speak about this, what I call the bizarre, strange aneurysm. We really don't know about what we speak, and that's one of the main concerns when we don't know too much about what we speak. So the first question is, what are we speaking about? We are speaking about aneurysm that do present according to different names and different classification and different quotation. The serpentine aneurysm, the so-called serpentine aneurysm, the so-called giant partially thrombosed aneurysm, or dissecting aneurysm, or fusiform aneurysm, or dysplastic aneurysm, or connective tissue disease aneurysm. It's pretty much difficult to understand what we speak about. Nevertheless, I will try to summarize what we speak about. My impression is when you look at all those different kind of names or description that have been given in the literature and that we share, every day in between us when we deal with the patient, my impression is that we are mixing appearance and pathology. And this is something that I really want to try to better discuss before moving to the treatment of the aneurysm itself. The pathology, we don't know exactly what is the pathology behind this because, a serpentine aneurysm is not the description of the pathology. We don't understand what's the cause of this serpentine aneurysm or a dissecting aneurysm or whatever. So, it can be immune, infectious, it can be inflammatory, it can be ischemic, it can be genetic, or more, maybe, causes that we don't imagine or we don't know precisely. So I think for me, it's a little bit confusing. Nevertheless, I will try to summarize this confusion, and there is a very nice description of this confusion when you look at a paper that has been published by the group of the Mayo Clinic, whose name is, the paper name is the Neurovascular Manifestation of Connective Tissue Disease, a review. This is what's written in the paper. There is a general lack of case control and prospective studies investigating the true prevalence of this finding in these patients' populations. Furthermore, the differences observed in the manifestation and histology of such disease pathology encourages future multi-center registries and studies in better characterizing the pathophysiology, prevalence, and ideal treatment option for neurovascular lesions in patients with cognitive tissue disease. So it's a dilution and confusion, a nice description of this dilution and confusion. So after understanding that I'm not the only one who is, asking for understanding better, I share the confusion with the team of the Mayo Clinic. Now, I share with you some pictures that were given to me by Pierre Lagenias. He was speaking about all this confusion, and this is the picture he was showing to explain what means the confusion. So if you look at those pictures that you see on the screen, you can say that you have a polylobulated local multiple aneurysm, a dysplastic MCA aneurysm with a slow flow, a segmental dolicho segment of the artery, multiple cavities in a partially thrombosed aneurysm, multiple lobulated lupus aneurysm, giant partially thrombosed aneurysm. Everything is possible when you look at this picture. So it's really mixing appearance and pathology. When you look at those aneurysm on the second slide, the upper part of the slide is clearly demonstrating, bizarre, strange, fusiform aneurysm that are completely different. And one is due to myxoma. The other one is an acute dissection. Clinically speaking, it was definitely easy to understand. Another one is a familial candidiosis, which is extremely rare, but it can happen and it can be, responsible of this kind of disease. And the lower part is one single patient. This is what Pierre Lagenias called the twin serpentine aneurysm. So what is the real underlying disease of this? It's pretty much difficult to know and pretty much difficult to understand. Does it play a role in the treatment of those aneurysms? Potentially, but except some cases that we will look at, sometimes it's not so easy to just say this is the cause of the aneurysm, this is the way you should treat it or you have to treat it, and this is a potential pitfall that you might share. At that time, he was showing a very interesting case. An 11-year-old girl who rapidly presented with a progressive hemiparesis with extraocular motor nerve dysfunction. And if you look at the MRI, you can see that something is the pumps is clearly related to a stroke. And if you understand, the supply of this area on the schematic drawing or in this cadavers injection, it's pretty amazing to see how many potential dangerous vessels are involved. And you really have to look at what's happening in these young ladies. When you look at what's happening, you don't see nothing. It's extremely bizarre. You can turn around, you can see, but you see nothing. You see nothing, except if you use, the new imaging possibilities, the new imaging system that we have, and especially when you do this 3D reconstruction with either the volume rendering or the surface rendering. And this is what Pierre did at that time to better understand. He saw something which is very bizarre, which is visible here on the surface rendering 3D pictures. And this is the inside reconstruction. And you can see that this, protruding, part of the endothelium of the vessel inside is very well visible on this inside reconstruction, which does correspond to what you see here. When you look back, you might see that probably here you have something which sounds a little bit bizarre, but it's really bizarre because you know that you have seen on the 3D surface rendering pictures that there was something, and which was definitely exactly at the level where the patient is presenting the stroke. So just a point which is extremely important, and Pierre insisted on this quite a long time ago already, at the very beginning of our acquisition, 3D pictures acquisition, that it was absolutely necessary to try to screen the inside of the vessel. The surface rendering reconstruction was extremely useful and giving a much better understanding compared to what we had to see before having this technology. So this is definitely something that is extremely important. When we deal with those bizarre, strange, and not necessarily a huge, partially thrombosed aneurysm, but dissecting aneurysm might be also very tiny little and might be responsible of complication. The very first thing I really want to eliminate is what I call the role of the clot. Whatever the technique that you are going to use to treat this aneurysm or those aneurysms that belongs to the category that I call the bizarre, strange aneurysm, this is the role of the clot. Quite a bit of those aneurysms are either partially thrombosed or not thrombosed at all, but presenting because they are big with a huge volume of either circulating, partially circulating and partially clotted clot, or more or less 100% clotted clot. So there is no question that whatever the endovascular treatment, the bigger the aneurysm, means that the clot that you are going to induce or to manipulate is definitely related to size of the sac. So the bigger the sac, the bigger the clot. And definitely, we do understand that for quite a long time now, and we do know that this is the real risk of the treatment of those aneurysms today, the bigger the risk when the aneurysm is big. And this is not something which is related to mechanical phenomenon. It's definitely related to what we call the proteolytic enzyme release. And those enzymes are basically the elastase. Elastase is an enzyme that we also use, in the lab to reproduce artificially on the rabbit, for example, some aneurysm that we do treat or we use for testing a new technology. Because of this proteolytic enzyme, which are attacking the wall of the aneurysm, it's an extremely risky factors, and the quantity of those proteolytic enzymes that are released according to the thrombotic process is depending on the size and the volume of the clot that you induce, which is having roughly two consequences, which is increasing the mass effect and leading to bleeding by destruction of the wall, because those enzymes are proteolytic enzymes. So we know that, and we have to fight or to try to fight as much as possible to avoid this kind of complication. So whatever the technique that you are going to use to treat this aneurysm, the very first thing is to reduce the volume of the aneurysm, circulating part of the aneurysm, understanding that progressively, if you reduce this, you definitely, I'm sorry, I have to answer a very important phone call. Just hold on a second. Okay. So the only way to reduce this mass of clot is to put coils inside, or you can put liquid at a given period of time. We were injecting onyx inside the sac of the aneurysm to replace the blood by onyx and to reduce the volume of the clot that is going to be induced by the treatment. This patient was treated this way. There was almost very little clots inside the sac of the aneurysm. It's pretty difficult to understand exactly where it is, but it's from the subarachnoid vertebral artery. So you can clearly imagine that if you occlude the parent artery, you will get rid of this aneurysm. You will get rid of this aneurysm, not necessarily sure, because once the clot is, growing, then you increase the release of the elastase. So after the occlusion of the parent artery, we notice that 6 days after the occlusion of the parent artery, aneurysm is visible here. We don't know precisely where the vessels comes from, probably perforators or something like that. There is almost no more sac visible, but there is quite a big clot. And because of that, we decided to control the patient with a CT scan, despite the fact that the patient was going pretty well. And we noticed that even one day post-occlusion, we had this, growing portion. This is the patent portion, this is the clot. And 6 days after the treatment, this clotting is growing. The patent portion doesn't seem to move too much, but the clot is growing and the wall of the aneurysm is changing. So it means that there is something which is destroying the wall of the aneurysm. And that's the reason why we really have to care about that. So understanding that the aneurysm was growing, especially at the level of the clot, we decided to pack as much as possible with coils the patent portion of the sac of the aneurysm. And as you can see that this is what we got immediately after the coiling, and this is 10 days after the coiling. There is almost zero portion of the aneurysm visible. Everything is fine. The patient is perfectly fine. No problem. No problem up to 16 days post-coiling and post-thrombosis where the patient got a bleed. So this is a phenomenon that we definitely are concerned about it. The first thing to do is to try to avoid as much as possible this elastase release. And that's the reason why from the beginning, the very first thing you have to do is not to occlude the parental tray, to put whatever stent flow diverter. You have to pack as much as possible with coil or with any kind of thing that you think are going to work to reduce this clot and to avoid this kind of complication. So there is no question that this is the key role of the treatment of giant partially thrombosed aneurysm, not to treat the aneurysm. It's not that difficult to treat today, but what's difficult is to control this elastase release, which is a major concern for the treatment of the aneurysm. So this was the first message I wanted to share with you. The second is, forget about what we are doing today. Of course, it's wonderful. It is just wonderful. So this is the second point I want to speak with you. And I call this second point, let's deal and eliminate the indication of the latest therapeutic development, which is a flow diverter stent. Because everybody is, oh, no, put a flow diverter, you know. It's not because you have a paint, you have a brush that you have to paint all the wall you face, but this is exactly what's happening when you see an aneurysm today. You put a flow diverter, which is a wonderful tool. There is no question about that. No question. That's also the reason why, because we have these flow diverters and because also the medical management of the patient in whom we deliver the flow diverter stent are much better under control with the new antiplatelet treatment. You know, this treatment is pretty safe. You know, we have more or less avoided the clotting complication. But the side effect is also that the bypass surgery is almost gone. You know, the rationale to produce or to perform a bypass surgery today is extremely, extremely rare. So we can always argue, we can always discuss, we can always think about it, but most of the time it's not necessary to do bypass surgery before the treatment of such aneurysm. So the flow diverter, this is a very typical indication. This large aneurysm, partially thrombosed, that was treated with coils. It has recurred, and then the flow diverter was deployed, and this is the result. Pretty much 100% of the time, you have this kind of long-term result. It's never 100%, but extremely frequently, you have this nice result with perfect reconstruction. You know, it looks like we are a plastic surgeon doing a cosmetic surgery. The sky is not as rosy as it seems, but we will discuss quite a bit of those indications. So nevertheless, flow diverter is definitely the way to go. So let's share some example of very typical indication of flow diverter. 61-year-old male, hypertensive, he got a sudden headache, which was partially treated with painkiller. 2 days after, he had an horizontal diplopia, and he came in the hospital with meningeal syndrome and a 6-nerve paralysis. He was loaded with clopidogrel and antiplatelet at that time. We don't use clopidogrel anymore, but at that time he was treated with clopidogrel and aspirin. This is what we saw. So obviously, this is a dissecting aneurysm of the basilar, which is visible here. There is no bleeding. Maybe a little bit here, tiny little bleed in the temporal horn of the MR. So no question, It's a fresh dissecting aneurysm which has bled. This is the screening of the rest of the vessel, not necessarily to test if there is not another aneurysm, but also to understand better the potential circle of Willis and potential collateral circulation in case you have to occlude the parent artery. Well, in this patient, it was not necessary, the cerebral artery was arising from the sac, which is a potential part of the problem. But nevertheless, I think it is a very, very dangerous aneurysm. This patient got a bleed in a dissecting aneurysm. There is no question that you have to give the best chance for the patient to get a good treatment. And the good treatment is, this is the treatment that was done. We have been delivering a stent and then coiling and then a flow diverter in the stent. You can argue that it's not necessary to put a scaffolding stent and a flow diverter, but this is the decision that was taken. And this is the result, 6 months follow-up, patient is fine, cured, no problem. So no question that flow diverter is a wonderful way to deal with those aneurysms. It's not always the case, and you will see. So this is another case, almost 59-year-old female, heavy smoker. In 2013, she had a right motor proprioceptive deficit, gait disturbances, and when the MR was done, we found a 20 millimeter unruptured basilar tip aneurysm. So look at that. Large aneurysm, not thrombosed, maybe dissecting, maybe not. At the time she went for the treatment, this is the clinical status. She had an upper limb deficit. She had a right Babinski. She had a central type of facial paresis and a mild dysarthria. The problem is, when we did the angiogram, we found that she had also fibromuscular dysplasia on the internal carotid artery with almost completely occluded carotid artery. And by the way, the vertebrae are not so well, but they are patent. So potentially there is some flow. And when you look at this giant non-thrombosed aneurysm, one can see that there is no supply from the carotid because it's almost completely gone due to the fibromuscular dysplasia. There is a little bit cross flow from the opposite side. There is some reflux in the PCOM when you inject the vertebral artery. So basically, it's not that, good for the strategy. So meaning that you have to try to preserve the patency of the basilar, considering the fact that the carotid artery is completely occluded. And so the very first thing we decided to do is first, of course, screening the aneurysm, looking at all these, MR. We even, did you see the movie? Do you see the movie or not?
No.
No? No?
No, Professor.
Okay, so let me quit with this because I have two screens, so one of the screen is probably okay.
We had some
okay,
problems.
so now you will see the movie. No?
Yes.
No.
Yeah.
You see the movie?
It's not playing. We see a
Well,
graphic.
okay,
We
but
see a graphic.
well, there
yeah.
is a
Yeah.
there is a concern, but it's not too much a big deal. I don't know why. So basically, we decided first to treat the carotid territory, and you can see that before and after the treatment, the patency of the carotid artery was definitely very good. So we are in a better condition to treat this aneurysm. So now we move back to the aneurysm, and let's have a look at the flow modification that has been induced by the stenting of the carotid artery. You can see here the reflux because of the flow here has been restored from the carotid artery. There is much less, vessel visible here because the carotid is flowing again. So this is extremely important. we play and we have to consider this flow modification and flow change when we manipulate the circle of Willis. So for that reason, we decided to deliver a flow diverter from the basilar tip to the left P1 segment and to jail the catheter to deliver the coils inside. So the main thing is not too much to deliver the flow diverter. The main thing is to try to avoid having this proteolytic enzyme release. And because of that, we might have a problem due to the elastase and the side effect of the elastase. So let me see if I can do this. Do you see the movie working now or not?
No,
No?
no.
Okay. So maybe I have to stop the copy of the screen. Let me check if I can manage this.
You start again.
No, I have to stop the copy of the screen. I change a little bit the setting of the system, monitors like that. So I put this here. Let me do it. No. So let's have a look now. Okay, so now do you see the movie or not?
No.
That's a pity. Okay, I don't know why it doesn't work. Let me check. Let me check another thing, which is okay. No. Okay. Doesn't work anymore. What's happening? Yeah.
Just starting the presentation over might help. Just like we
No, you know the problem because I have two screens, and because of that,
yeah, conflict. I can't help you there. Are you trying it again, Doc?
okay.
We have some problem with the time, Professor.
Oh, okay.
Yeah. Well,
It's tricky using two screens.
yeah, it's I'm sorry. I'm really sorry, but I quit the screen. Now I do that.
When you start again, it might work. Try it again.
I will.
Put the presentation on
Don't worry.
now, and it might work.
No. Okay, I don't know. I will try to do my best. Let me start again.
Okay. It might work.
No, full screen. Okay, I stop and I start again.
Okay. Hmm. How are you doing, Dr. Murray?
So Bennett, we had some problem with the time. Sorry.
Dr. Murray, you there? I think he's having problems with the system.
Yes.
He'll be back. I wanted to show you some pictures of Miami. I don't know if you can see it here. You can't see it. I can't. That won't work.
We continue with the Dr. Luis.
Let's just wait a second. Usually, let me just usually the speaker will come back quickly.
Okay,
Yes.
Oh, okay.
is it okay now?
No, you're not sharing now. You need to share.
Okay, I will.
Okay, you're back.
And now?
Yes, it's working.
Okay, so finally. So I remember what was the problem of this patient. She had a
What are we doing,
coils.
Doc? What are we doing, Doc?
Sorry?
Okay, we're ready to continue.
Is it okay? Is it okay? Can you see everything?
Yes.
Okay. So what we see is, the aneurysm has some part of it which is not completely occluded. We don't know exactly what it is, but it doesn't seem to be a fresh blood. The real concern is that when you look at the angiogram, there is definitely, after 36 hours, compaction of the clot, of the coils inside the sac. The sac is a little bit growing again. And look at what you see. just by looking at the pulsation of the coils inside. So when we saw that, and despite the fact that the patient has, a stent inside, we decided to put another stent in the first one in order to try to reduce as much as possible the connection from the aneurysm to the parent artery. So after doing so, immediately after the delivery of the second stent, 36 hours later, in a telescopic ways, we noticed that, the P1 on the right side has disappeared by the flow constraint. It's, two flow diverter in telescopic ways, which is not too much a big deal because we know that there was some PCOM connection. And finally, we could obtain a pretty nice exclusion of the aneurysm. And let's have a look at what we see. You have on the left side of the screen the post 12 days later, and then 1.5 months later. So let's have a look at what's happening. This is what we see. Progressively you see that the edema around the sac of the aneurysm is definitely getting better. The sac itself is decreasing in size, and even the resorption of the transventricular resorption of the CSF is getting much better at the same time as the sac is shrinking. So, it's important to really check what you are doing, even if you did a good job, you put the flow diverter, you put the coils. If the patient is worsening, it means that the protection of the aneurysm is not strong enough. And don't hesitate, even if it's 3 days after the delivery of the first stent, to put another flow diverter in a telescopic way and to get a wonderful result. These flow diverters are definitely wonderful. All those dysplastic, fusiform, dissecting, I don't know exactly how to call the aneurysm. When you have to deal with that, delivering a flow diverter is just extremely easy as far as you have, the experience to deliver it. It's not that complicated, and you can get a wonderful treatment of this aneurysm. This is a few months later. You see the perfect reconstruction of the parent artery, and aneurysm is gone, and patient is definitely fine. So there is no question that in those bizarre aneurysm, the flow diverter is the way to go, compared to what it was before the treatment. Many of those, bizarre dissecting dysplastic aneurysm are today easily treated, easily quote. Do you see me or don't you see me?
Yes, we see.
Okay. So you see the aneurysm, this aneurysm. We delivered a flow diverter, and this is the vasosity, which is always used to screen how the stent is opposed to the wall of the aneurysm and the wall of the parent artery. And this is some months later, complete occlusion of the aneurysm and perfect reconstruction of the parent artery, and the patient is fine. So there is no question that this is a revolution. The revolution comes also by the fact that we have many, many tools to reconstruct those arteries, even if, the dissecting aneurysm is involving a bifurcation. This is a typical dissecting aneurysm of the bifurcation, partially thrombosed, as you can see here, partially thrombosed. And you check, what is the best way to bypass the neck of this aneurysm, and we decided to switch from here to here with a pretty heavy system, a scaffolding stent with a Leo, and then 2 silk in a row in a telescopic way. So this is a pretty tricky treatment with the scaffolding first, as you can see, and then the delivery of the flow diverter inside the scaffolding stent. This is the vasosity showing how much, we are opposing to the wall of the vessel and crossing the neck of the aneurysm. So there is no question that you can do wonderful thing. And this is a 14 months post-treatment, and this is a 20 months post-treatment. Even, the vessel that was arising of the bifurcation has been preserved. The sac of the aneurysm, which is still a little bit patent here, is no more visible after 20 months. And we can definitely accept the fact that this is a tremendous result compared to what it was before. And there is no question that without the flow diverter, we cannot really do this kind of job. And as you can see, how the patient is happy to have this treatment done. Another incredible case, this is an 18-year-old patient who presented with this aneurysm that was diagnosed because of mass effect and headache. Very complex intrication of the middle cerebral artery, which doesn't exist really. As you can see, here we have the PCOM and the connection with the carotid. This is the middle cerebral territory, which is completely dysplastic due to this bilobulated, huge dilated aneurysm. So what we decided to do after screening this, you have here the carotid, the PCOM, A1 a little bit visible here, and then the middle cerebral artery. We decided to navigate from the posterior circulation, so at the same time we can bridge and cover the origin of the vertebral territory here. So, we come from the posterior circulation through the PCOM, and this is the course that has been done. So again, we have been using scaffolding and flow diverter, 3 flow diverter in a telescopic way. You can see that immediately after the treatment, there is a stagnation of the dye on the sac of the aneurysm. And this is a 6 months of follow-up as expected. From the posterior circulation, we have been able to reconstruct completely the middle cerebral territory. The carotid artery, which was dysplastic and dissected here, has been occluded by the coverage of the stent, which is here. And the patient is absolutely perfect. So no question that, the reconstruction of this parent artery is incredible. And just to show you that with some training, you can do tremendous things.
Professor Moret.
This kind of, yes?
So sorry, it's a time for the Dr. Luis.
Okay.
Any problem? Sorry.
No, it's okay.
Diaz Mascamotos.
I am so sorry.
Okay.
It's okay, Luis. You can go ahead.
No, 10 más minutos, okay?
All right.
You want me to
sorry.
continue?
Sí, pero 10 minutos, por favor.
All right.
Okay. So I show you another example of reconstruction, again with scaffolding stent. And this is a beautiful long-term follow-up 18 months later, compared to what it was before. So no question that it is just amazing. It's amazing even when it happens at the pica level. You can deliver a Leo stent, which has 2 Leo stent in a row. It's not really a flow diverter stent, but it's diverting the flow. There is no question about that. And you can see how efficient it is. So the diversion of the flow is the way to go, including when you have this tiny dissecting aneurysm at the pica level again. You can protect the neck, put the coils because it was done in emergency. You put the braided stent in front of the neck, and you get this wonderful result. As you can see here, like as you increase the size, you have a perfect reconstruction of the parent artery. So it's amazing what we can do. It's amazing what we can do in this again. So I show you multiple examples just to show that this is not one case. It's extremely efficient to reconstruct the parent artery using this technology. So going more distal and going further, giant partially thrombal distal aneurysm, as you can see. The 3D picture is clearly demonstrating the neck of the aneurysm. But if you think about where it is, this is extremely distal. if you look at the AP view, it's a M4. So we navigated through the sac and then to extend. And today it's possible with a tiny little flow diverter navigating through the 17 microcatheter, as you can see, to bridge the neck of the aneurysm. We didn't put any coils inside the sac of the aneurysm for, reason that we don't really explain, because we should have to, except the fact that it's a true partially thrombosed aneurysm with a big clot, and the portion of the aneurysm which is patent is not that much. So we consider the fact that the complete occlusion of this aneurysm at the neck was enough without delivering coils. The sac is big like that if you follow the arrow. So this is a 6-month control angiogram. The aneurysm is gone. The parent artery has been completely reconstructed. So there is no question that this is extremely, extremely useful. Another case to show you that you have multiple indications that were not really possible to treat before. A 62-year-old man. He was supposed, when he came with a sudden aphasia and looking at the DVI and the MR, to have a stroke. So that's the reason why he got an IV thrombolysis. It's very distal and no mechanical thrombectomy. 5 days later, he was discharged from the hospital, and with anticoagulation treatment, thinking that probably the etiology was a cardioembolic origin. The problem is the day after he exited, he went back with an hemiplegia. The NI score was 11, and the MR is clearly showing an evolution of this bleeding, which was supposed at the beginning to be responsible or related to the stroke. So seeing that, which was a little bit bizarre to have an hematoma which is growing, so we decided to do an angiogram, and at that time we saw that there was a tiny dissecting aneurysm. We don't know if it's mycotic inflammatory or whatever, but this is definitely the reason why the patient bled, as you can see here. And just to show that today it's not a real concern, we can navigate with a tiny little flow diverter in a 17 microcatheter, deliver the Vista baby, right in front of the neck of the aneurysm, and have this wonderful, follow-up with even the patent artery, which is completely patent 3 months after, and the aneurysm, which is decreasing. This is 1-year follow-up, a complete resorption. The patient still has a little bit of difficulty to to speak by word findings, but he's completely cured. And this is a 3 years follow-up. Even 3 years later, you can see that the parent artery is patent and the patient is fine. So this is the second point that I wanted to discuss, how easy it is today and how efficient it is today to treat those bizarre aneurysms. But nothing is perfect. And now I'm going to show you what's not perfect. What's not perfect is definitely an aneurysm like that. So you can partially thrombose aneurysm. You can think about, reconstructing the way you do it usually, scaffolding, flow diverter inside and everything. This is the structure. And this is before the treatment and after the treatment, post-stenting. Everything is patent. There is not too much patent portion of the sac of the aneurysm. There is a big thrombosed territory. The patient is fine. So we did a control angiogram 2 months later, and we found this. So there is a shrinkage of the patent portion, but there is something which is bizarre here, a kind of channel. We don't understand too much what it is, except when you do a vaso-CT. And when you do the vaso-CT, you can clearly see that it happened that, sometimes the stenting is thrombosing and the flow has been rerouted through the clot. So now we have a true serpentine aneurysm, and the distal part of the stent has been reperfused by the flow through the thrombosed portion of the sac of the aneurysm. So as I said, nothing is perfect. Of course, now it can happen. It's not that frequent anymore because the antiplatelet treatment is definitely much better compared to what we have. Now, the third portion and the last portion of my talk is the role of the parent artery occlusion. There is no question that today, despite the fact that we have the possibility to reconstruct the parent artery, it's not always the right way to do it. So I want to speak about the deviation or the flow rerouting. The flow rerouting is something that we know and something that you have to understand how it works. And the basilar territory is definitely a very good way to demonstrate the way it works. If you trace a line right in the middle, just around the level of the middle cerebellar artery, you have two territories, one above the ICA and one below the ICA. Those two territories are completely different. The one which is above the ICA is a risky territory. The one which is below the ICA is a very safe territory because there is no true perforators at this level. It's always the perforator or the so-called perforator at this level are joining a PN network, and it's never true perforator, which is not the case here at the upper part. The above ICA territory is a risky one because here you have the true perforators. This is something that you really have to keep in mind. So deconstruction means reorganization of the blood flow. The vessel side will adapt. There is no question when you change the circulation of the flow, you readjust the pipe to the circulation, and the collateral should be reorganized and adapt also to the new blood flow. So it's clear to explain this when you look at those two buildings. When you have this tower and you have to bring the water in this tower, it's not the same concern as when you have to bring the water in this one floor, very nice south part of the France village. For this one, you need a big pipe, which is an enormous one. And for this one, you need a regular pipe to bring the water. But if you change the flow, and if you transform this big tower in a flat, one floor houses, then the pipe will shrink and get the same size as it was for this one floor fitting. So, what's happening is a shrinkage of the pipe after modification of the flow. This is extremely important. This is the basic system and basic principle that we use when we treat those aneurysm with parent vessel occlusion. We have to take advantage of the territory which are able to sump the flow, reverse the flow, for example, at the level of the basilar. If you put a balloon here, you can have a reversal of the flow due to the sumping effect of the ICA territory. If you occlude, here at the level of the vertebral artery, subarachnoid vertebral artery before the origin of the pica, then you reverse the flow the same way, but really a bit more distally. So this vacuum vascular territory, you can play with it. You can occlude one here, one above. You manipulate the flow modification according to the anatomy of the patient. So these are the occlusion site, and then you get refluxing, and by refluxing, changing and reducing the territory, the pipe will shrink and the aneurysm will shrink at the same time. So you take advantage of this flow modification, and the dissecting part of the vessel is also the safe place to occlude. If the patient has no symptoms or no deficit at the level of the dissecting artery, it means that there was no perforators, and this is the safest place to occlude the artery. So if the patient had a stroke, he already has a stroke because he got the dissection, so it's rare to have to add a new stroke to the stroke because the damage has already been done. If the patient had no stroke, it's because the dissection is not involving the perforators. and then you can definitely think about occluding nicely the basilar territory. So this is an example of, how it works. This kind of aneurysm, there is no question that you can put a flow diverter and get a good result. But as you know, sometimes you get also problem with the flow diverter, especially when this patient is presenting with this aneurysm and a subarachnoid hemorrhage. So you better try to get a complete cure of this aneurysm as soon as possible. So what we did the test occlusion under general anesthesia. And under general anesthesia, you can clearly see how much you can supply retrogradely the flow in the basilar. And there is no question that this part of the basilar is the most risky part. But as far as you got flow through the retrograde flow because of the modification of the direction of the flow due to the balloon occlusion that you do when you proceed with the balloon test occlusion, you can clearly understand that the most dangerous part of the basilar can be safely preserved, and the aneurysm can be treated if you occlude it very nicely. So this is exactly the principle of the technique. As you can see, there is no slowing of the venous phases and anything. So we just plug the sac of the aneurysm right at the level of the dissection. Don't get above, don't get below. And then you can get this wonderful control angiogram with a nice reperfusion retrogradely up to the level of the ICA and the occlusion of the basilar. So this is one way, specifically when you are dealing with a patient, a pretty young patient presenting with subarachnoid hemorrhage in the acute phase. It's not that spectacular if you compare to the flow diverter, but it works also very nicely. It works also for this kind. You can admit that it's not easy to put a flow diverter in this aneurysm where the dissection and there is no thrombose, but there is a huge dissection of the whole basilar tip. Again, if the patient doesn't present with any neurological deficit or a very tiny little neurological deficit, means that the dissection, which is involving the whole basilar tip division, is not involved in the perforator, is not involving the perforator. So what we decided to do, we decided to protect as much as possible the patency of this upper part and to put coils in the sac of the aneurysm. So of course you check by occluding, doing the test occlusion to see how much and how well is functioning the circle of Willis. And this is finally what we did. We put the stent here and we oppose the coils in the sac of the aneurysm up to the level of the stent. Here it's a pretty narrow stent, but it's nice perfusion. So the sac is packed with the coils and the stent is there. Again, it happens sometimes when you do the control angiogram, despite the fact that the patient is perfectly anatomically clean with absolutely zero neurological deficit. 9 months later, you have this wonderful treatment of the aneurysm, but there is no more filling of the distal part, which means that at the level of the dissection, after thrombosis inside the stent itself, there is no perforators involved in the dissection, which was something that we were expecting, but of course we would have loved to preserve the patency of this. Nevertheless, the PCOM are functioning and there is no concern with the posterior circulation. Another case where it's pretty difficult to imagine that you can place a flow diverter. And is it safe to do it? Definitely, it's not that easy. Especially so, what we decided to do in this situation, we decided to do a parent artery occlusion. First, we check the possibility of the circle of Willis with balloon. As you can see here, the balloon is there. And then we pack. We pack the sac with the coils, and inside the coil we added onyx to be sure that in those huge aneurysms, we can reduce as much as possible the clot volume to avoid this thrombolytic enzyme release. So this is what has been done. This was in November 2002. The parent artery was closed. And this is when you do the control angiogram a few months later, you can see that because of the flow constraint, there was a tiny little aneurysm that has developed at the level of the peak arm. So what we decided to do, we place a balloon with a catheter inside. We deliver some coils inside this aneurysm. The patient is perfectly fine. And then at the very end, we had a stent in front of the neck of the aneurysm, a braided stent to have a flow diversion effect. So this was in July 2005. And in June 2007, this is what we saw. The aneurysm has grown dramatically. You know, it's another disease. There is no question that something is happening. This is a contralateral thing. So what we decided to do at that time, this is where the stent was delivered. You know, we place a balloon, we coil, and then we put another stent in front of it. And then we pack as much as possible with protection of the stent. And this is June 2007 and January 2011. As you can see, both aneurysms are gone, no more recurrences. But this patient has a funny lindo. It's a tiny little hemangioblastoma, which is not really moving too much. And for the time being, we don't touch it because it doesn't change, it doesn't grow. So, you know, the parent artery, occlusion is definitely a way to deal with those terrible aneurysms. At the level of the P2 segment, there is no question that is a very, very nice way to treat the aneurysm, despite the fact that you know all those branches that are, supplying the peduncular area, supplying the geniculate arteries, and this very important function at the level of the midbrain. But there is no question that the dissection level doesn't involve the perforators because the patient is clinically intact. So you can safely occlude. And most of the time, the reservoir, which has developed after the dissection, is already slowing the flow and induces development of a collateral circulation. So this is the collateral circulation that has developed. As you can see after the occlusion, there is a retrograde feeling. It's an extremely right and good way to treat the aneurysm. This is a pretty old case. At the time we had detachable balloon, we could perform the test occlusion with the detachable balloon and detach the balloon when the test occlusion was fine and look at how efficient it is regarding the shrinkage and the treatment of this aneurysm. So all those dissecting aneurysm at the level of the P2 are also very well and very safely treated by parent artery occlusion. You can do the same when you deal with the middle cerebral artery branch, huge dilated, one single exit. This is the test occlusion. You can do it with the coils you pack without detaching. It gives you time to screen how the retrograde flow is obtained. And this is what you can see. You have a perfect retrograde flow up to the level of the sac with occlusion, and then you detach the coils and you get the treatment. Serpentine aneurysm, there is no question that the channel which is going through the clot of the aneurysm is a major concern. The parent vessel occlusion, for me today, is still the way to go. You do the test occlusion with a balloon, then you can plug with coils, and then you can get this very nice treatment of the aneurysm. The mass effect is still visible, but it shrinks with time. As you can see, there is a retrograde flow from both sides, and this is definitely the best way to treat the aneurysm. I really emphasize the fact that don't try to do anything with flow diverter in those aneurysms. You just better occlude the channel inside the sac. And this is what you see before the treatment. This is after injection. There is a huge activity on the wall of the aneurysm, and this huge activity is definitely related to the clot that is inside the sac of the aneurysm. This is a case where you have a huge portion which is occluded and another small patent portion. Again, don't try to put a flow diverter or whatever to reconstruct the parent artery. You just test the occlude to see what's happening. There is already collateral flow that is developed from the posterior circulation. You can place a small balloon, check the collateral flow. You can use, superimposing a mask which is in black and a mask which is in white. So you have a clear understanding of all the flow you gain from the posterior circulation and from the anterior circulation when you perform the test occlusion, which is done under general anesthesia. When you wake up the patient, you keep the patient with for a few days with a higher blood pressure compared to the mean pressure of the patient, and you get a good result. Another case to demonstrate that the place of the dissection is where the occlusion is safe. This is also a difficult case to understand and to think that you will be able to treat with a flow diverter. Don't care about this one. Just plug the sac itself at the level of the dissection. Get this complete treatment of the aneurysm. Patient is fine. This is the safest way to treat this aneurysm. You don't need any antiplatelets and you just occlude it. You can reverse the flow as far as you check with the balloon how to control the flow. This is multiple example of occlusion with the balloon, and you can see that we have a good reflux using the sumping effect of the pica here. So after checking how we can balance the flow, we decided to reverse the flow this way by occluding the basilar just proximally with the coils. And after this occlusion, as you can see here, if you look at what we saw when we did the test occlusion, you have the reversal of the flow in the basilar system up to the pica, inducing a shrinkage and a complete exclusion of the aneurysm by remodeling of the vessel, exactly the same thing as we demonstrated on the picture using the one-floor house and the big tower. So this is the end of the talk. We have been speaking about this very bizarre and difficult aneurysm. We have been mixing appearance and pathology. No question, this is a problem. But for treatment of bizarre and strange aneurysm, in terms of conclusion, I would say that the flow diverter stent is the key step, but not always the only one. And as you saw, we still have the possibility to treat those difficult aneurysms by parent artery occlusion after checking the collateral circulation. So it's finished for me.
Thank you very much, Professor Jacques Moret.
I'm sorry I took quite a bit of time, but Louis told me, go ahead. So.
Okay, I am pleased to introduce to our my professor, Dr. Luis Lopez Ibor, an interventional radiology from Madrid, Spain. He's internationally recognized for pioneering work in treatment of cerebral and spinal vascular malformations through embolization. Today, he will present a fascinating case titled Endovascular Treatment of Serpentine Aneurysms. Through his expertise, he will explore the complexities and advancements in treating in this type of aneurysms. Yeah. The floor is yours, Professor.
Sí.
Okay, Luis, primero quiero decir Dr. Moret, gracias.
Sí.
No estamos muy bien preparados, pero vamos a mejorar. Gracias para su charla magnífico. Yo trabajé con un gigante antes, Yuha. Tú estás en la misma clase como Yuha, yo creo. Okay, Luis.
Yes. ¿Puedo presentar ahora o no?
Sí.
Yes.
Ok. El segundo es, hay que darle a compartir, ¿no?
I have to reconnect because it's
Ok, yo
disconnected.
puedo,
from me.
ok, yo puedo sacar de su panel. Ok, 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 listo.
A ver,
Ok,
ahora yo puedo, ¿no?
sí,
¿Qué pongo? Compartir, ¿no?
sí.
Ah, compartir es esta, yo creo que es. A ver. Sí, compartir. ¿Es ok?
Sí,
Yes.
Sí,
Ok.
sí.
Bueno, good morning, good afternoon, everybody. Thank you very much. Professor Jacques Moret is my friend. My talk is the same of the Jacques Moret because my teacher is the same of Jacques Moret, is Pierre Lajunias. Do you remember when I stayed in Paris with him, 80 to 86? Okay, the name, the serpentine aneurysm, is a making name. Moret explained very well. It's possible is dysplastic, it's possible dissecting, it's possible elastorexis, whatever you want. I like to present only some case, typical case of this complex pathology. He explained fantastic, Professor Moret. The cases are incredible, but sometimes so you are very good technician, the technique is not well. So sometimes I like to present the complex case and the difficult evolution. First case is a 7-year man, 7-year with neurofibromatosis. This is MR. This patient is treated by myself in Colombia and have bilateral aneurysm and dysplastic aneurysm with Recklinghausen disease. Also, you are in the posterior communicant artery. You are here, the dysplastic. I treated partial, but then don't touch more because it's the dysplastic is very difficult at that time. Don't have the flow diverter. The second case is 2-year-old boy. He comes in my hospital with ventricular hemorrhagic grade 4 when I arrived to a hospital. 2 weeks after bleeding, coming in my center, I diagnosed this dysplastic aneurysm, fusiform pericallosal aneurysm, AP view, late phase, oblique. And I decide, because it's impossible to navigate to the balloon, I decide to put the coil to test occlusion with coil. Test occlusion. The patient is general anesthesia. With the test of occlusion with coil, you are here the stagnation of the contrast, and you are here the collateral leptomeningeal circulation is still open. I decide to liberate the coil in this point, and you see here the collateral circulation, and the patient like perfect. And 3 months later, the control, you are the normal or stable morphology of this part of the aneurysm is not open. This patient is treated by me about in 95. Second case, complex, similar to present Jacques, is a female, 40 years, fusiform petrous aneurysm, but the patient have thrombosis in the right side, the siphon is thrombosis, the carotid in the right side is only done the ophthalmic, two external and internal bypass anastomosis treated for this patient don't work. Look here, the contrast come here, communicant, and you are the middle cerebral artery. You don't have the posterior circulation. I decide to navigate the balloon to mark distal and wait few minutes. The patient is with neuroleptoanalgesia. It's possible to check. This is the right carotid. You only the ophthalmic with anastomosis, with the pharyngeal. And this is the after close the carotid. 24, the patient is well. 24 hours after, the patient developed one hemiparesia and aphasia, but good evolution and asymptomatic 1 year later. This is the MR after embolization. You are the clot, total thrombosis of the aneurysm. This is the control angio 5 years later. You are the vertebral, both carotid is closed, one with by myself with balloon, another one with another situation, and the parenchyma is perfect in the middle cerebral artery and the posterior, and the basilar artery have a new lesion, this small change of the wall. 5 years later, at the beginning. The patient come 1 year after this angio to my consultation and bled and dead, massive hemorrhagic. Another case, this patient probably is Marfan syndrome, Marfan syndrome, elastorhexis. This is another treated by myself in 91 in Madrid, Reclining house in 6, have two external and internal anastomosis. After put the balloon here, you are the thrombus. And this is the final control, and the patient rests well. The last case is a case I think Jacques know the beginning of this case, but don't know the final. It's a 53-year-old man, have a clinic dementia, thalamic dementia, progressive cognitive decline, change in language. Is typical patient to the expert neurologist. The patient have one aneurysm with edema around. This edema problem is pulsability of this aneurysm. AP view, you see here the change, the gliosis around or edema. Also have old infarction in the external capsule. And this is the aneurysm. This aneurysm, AP view, 17, and the final, you are two vessels, posterior cerebral artery and superior cerebral artery. Lateral view don't have the communicant, posterior communicant open. I decide to treat with the Leo stent in this period, the distal part to proximal part. You see here very well the posterior cerebral artery and superior cerebellosa artery. This is a complex because I decide external internal anastomosis maybe is possible here, here. I don't know if in the same time is possible. In Spain, no. This is the catheter inside to the posterior cerebral artery. 1 stent, 2 stent, 3, 4, 5 Leo stent. And this is initial angio. Pre-stenting, 1 month later, 2 months later, 6 months later. Total reconstruction of the vessel. I am happy, I am credible, and 1 year later, this is the CT scanner, sorry, in 10, and this is the CT scanner in 11. You are growth, the aneurysm, but I no, I understand because the reconstruction is okay, but look that you are endolink. 1 year later, total reconstruction, the patient have a reopening on this part and in this part. Why? I don't know. Maybe it's the thrombus, maybe it's the cells. Look that. And in this situation, bypass is difficult because the posterior cerebellar arteria is not touched. More flow diverser. The difficult is the distal part is very, very, very small, overlapping more stent. Proximal occlusion on holidays to the patient. I decide to put more overlap Leo stent. And
Good decision.
a good decision. Yes,
Good decision.
yes, thank you. Look that. After place this Leo stent, thrombus of the distal part and the thrombus on the posterior cerebral artery.
But you didn't angioplast? Ah, yeah, you angioplast.
I
Yeah.
looked at angioplastia, rupture,
Ah,
kaput. But I decided in this moment to close the vessel with coiling
mhm.
because it's the very bad situation. And this is the final. The patient have infarction of the posterior cerebral artery, sterilization. And 1 month later, the patient is dead. This is an example I like to present only to complete complementary case of Professor Jacques Moret. Thank you. It's okay.
Well, Luis, thanks for sharing these interesting cases. Once again, I think unfortunately the patient is also exposed to potential thrombosis. Those thromboses today are definitely much less frequent because of the better antiplatelets that we can use. But despite the fact that we have some coated stent, we still have potential complication due to clotting, especially when you deliver several stent in each other in a telescopic ways, and especially when there is a big discrepancy between the size of the channel through the thrombus and the distal part of the vessel, which has happened in your case. So there is no question that it's difficult. Now, one thing which is important is probably I would have tried to see if there was any possibility to occlude the parent artery before adding a stent. We try always to see if there is a potential way to occlude the parent artery to have enough collateral circulation, because this is definitely the safest way in those crazy large partially thrombosed and serpentine aneurysm. So the strategy is, before you start thinking about reconstructing completely the parent artery, be sure that it's not possible to occlude the parent artery, because this is definitely a very safe way and less risky procedure.
I thank you, Jacques. I totally agree with you. So if you want, in next session, I invite you to discuss and present the total occlusion of the basilar artery in aneurysm. I have 7 cases.
Sí, esta idea es exactamente que it's a round table. The
Yes,
round
a round table.
Yeah. Es la idea que él está
Jack,
comentando durante tu presentación.
And Professor Moret is my
you
professor.
You can speak, everybody can speak. I am open.
No, good, Jacques. The question, your question, the anti-platelet, and every discussion is important. But one thing, one question for you. In my opinion, the soft stent is flow diverter, is soft stent. Leo is soft stent, but is the pulsability of the artery going at the same time of the pulsability of the stent. And this is sometimes this is the reason you reopening the sac. But with the balloon expandable stent, I have some case. Do you know 2 cases for me? I sent you many years ago. The rigidity of the balloon expandable stent is high to preserve and draw the pulsability of the vessel inside the aneurysm. What do you think from this comment?
Well, no, honestly, I am not in favor of the more rigid stent. I think the risk of having a problem with regrowth or no healing of the sac of the aneurysm.
Excuse me, Dr. Moret, move your camera. We're looking at your stomach.
Move the camera.
Look, there we go.
Okay.
I'm sorry, because
Okay.
with these two screens, I even don't see my face on the screen, so I don't know what's going on. But nevertheless, honestly, I think that when there is any leakage, I think we have to add another flow diverter. Of course, the more you add, the more complication you might face due to clotting. But it is not a real concern because now with the cangrelor, with the ticagrelor, with the prasugrel, we have a much better control of the potential clotting. So, those aneurysms are terrible disease and the patient is going to die. And I think that we offer a better option for the patient to, add another flow diverter, exactly what you did. The question is, it's not because you did what I thought it was good to do that you are not exposing the patient to a complication. It means that what was the other option? The other option was to test occlude if the patient could tolerate the parent vessel occlusion. Where you were inside the mesh of the stent, it was not difficult to place the balloon to test occlude at the origin of the posterior circulation and to see if there was a possibility to get a retrograde flow and to salvage the distal territory of the PCA. This is the only thing that I would have done differently compared to what you did. I would have first test occlude, and if there was a good potential collateral circulation, I would have privileged the parent vessel occlusion compared to a new stent. But if there was no potential collateral circulation, I would have done what you did, which is another stent. Depending on when did you do this case? A long time ago, a few years ago?
Yes, I don't have
Yeah, so a
an
few years ago,
experience. Yeah,
the
yeah.
regiment
Only the balloon, only the coil.
yeah.
Yes.
No. So that's a real concern.
I agree. I agree with you. What do you think to reply the sac when you put one now, today? One
No,
stent?
today I would do exactly what I do. First, the risk of clotting.
Yes. You testing, you put the flow diverter, whatever. What do you think to reply the sac, not with coils, with onyx?
It's more difficult. I did
Yes.
quite a bit of onyx in aneurysm. It's good to reduce the volume of the clot. It's better if you have coils and then you can inject the onyx inside the clot because it saves a little bit of the side effect, which is leakage of the onyx. Onyx is a pretty fluid, so it can leak and then you get an occlusion with the onyx. So it's possible, there is no question. I would advocate that if you want to do so, you put coils and then you can inject onyx in the sac. You can use onyx 38 or 32, I don't remember the number, which is a little bit more viscous. So you have less leakage because the goal is not to get close to the neck of the aneurysm. The goal is to occupy the space. And as far as you occupy the space, you reduce the risk of enzyme release. So no question you can do it. You can plug with coils. You do what you think you are feeling comfortable to do it. I don't feel comfortable to inject onyx in an aneurysm. If onyx is used to treat the aneurysm, which means that you have to bring the onyx at the level of the neck. It's never possible to avoid leakage of the onyx, even if you put a balloon in front of the neck, because the balloon is covering the catheter, which is inside the sac of the aneurysm, and there is always a groove in between the balloon and the catheter. And when onyx gets close to the neck of the aneurysm, it leaks along the groove in between the. So, I don't advocate to do so. I prefer, to keep on packing with the coils and then to put flow diverter on the neck.
Yeah, we have a comment by Ronaldo. Go ahead, Ronaldo.
Yes, very impressive case. I have a question. I am in Latin America. For example, when we have some case of this difficult case, what will your recommendation? Go back to the neurosurgery or to use normal stent with coils or don't do nothing? For the Monsieur Professor Moret or Professor Luis Lopez Ibor, what will be your recommendation for us here in Latin America? We don't have all this stuff, or I mean, all this technology sometimes for the economy. I'm sorry for the question.
No, I do understand the question. I have very frequently this kind of debate when I go to South America. I'm not saying that this is specifically a problem which is related to South America, but the medical system and the medical healthcare environment is sometimes difficult for the patient.
Yes.
I do recommend that, if you have concern with money, if you cannot get access to those devices, there is a very good way to do it, which is first to try to think about the parent vessel occlusion. The parent vessel occlusion works easily in those aneurysms in around 50% of the case. So,
Right.
it is safe because you can control precisely the collateral circulation. And as far as you have a real view of the collateral flow when the patient is under general anesthesia, it means that when the patient will wake up, the blood pressure will be higher and perfusion from the collateral circulation will be better. So the risk of having a complication after a parent vessel occlusion when you have a real collateral circulation, which has been demonstrated at the time as you do the test occlusion, is extremely low, extremely low. And a lot of people, they don't believe that, but trust me, I did a lot. We don't do that many today because we use a lot of flow diverters, but each time it's complicated. For example, the young patient, 18 years old, that I showed with a complete reconstruction coming from the posterior circulation, it was painful to do it, technically speaking, but there was no other option. He could not tolerate the occlusion of the parent artery. We could have think about doing a bypass surgery, but having a bypass surgery, I did the treatment in Egypt, was pretty difficult. And I had the feeling that it was possible for me to reconstruct the middle cerebral artery coming from the picon. And obviously, this is what was done. So in this case, I could not occlude the parent artery. If the parent vessel occlusion was possible, I would have occluded the parent artery with no question, without trying to reconstruct the parent artery. A lot of us reconstruct the parent artery without knowing if it's possible to occlude the vessel. There is a positive way when you do so, because you never know what can happen. You did a perfect treatment with a parent vessel occlusion, the patient is fine, but then he got a car accident and he has a dissection of the other vertebral artery or the other carotid. So theoretically, you expose the patient to more complication. It's better to have all the vessels open to supply the brain. But, if you balance between doing an heroic procedure to reconstruct the parent artery with all the tools we have and a simple treatment when it's possible done with a parent vessel occlusion, you better choose the parent vessel occlusion. It's not beautiful when you look at the picture, but it's extremely useful, extremely safe, and extremely efficient. There is never any recurrence in this treatment.
Yes. Oh, thank you very much, Professor. Very wisely advised. Professor Luis, yes.
Well, yes, for response your comment, I treated many patients with you in Tabasco.
Yes. You know the special.
And in other country in South America, Hispano America, that you know very well.
Yes.
to respond your question, see if you have a neurosurgeon or your material, your device to treat, you treat. Don't wait.
Yeah.
Don't wait. Don't go into the congress, to the meeting. I have the blah, 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 blah. No, no, no. The patient is the patient. And then
Yeah.
when you have the difficult case, you put the question a Professor Moret or another.
Oh, thank you. Thank you so
You
much.
come, it's possible the patient going. For me, it's most easy to treat the patient in Madrid than to treat in Villahermosa, no? Do you remember?
Oh, yes, of course. you,
Well,
you know the
despite the
pain.
fact that, I am going quite frequently in Colombia, and, I have seen wonderful treatment performed with all those new
Wonderful
tools.
woman. And
No,
wonderful.
woman, yes, but wonderful treatment. So I do understand that sometimes the patient doesn't have the coverage from the insurance company. But in Colombia, it's not so frequent. Most of the patients, they have coverage.
No, Jacques, no. I treated the patient in Colombia. I start in 1995. I don't have nothing. Colombia,
No,
blah,
but
blah, blah. My
Colombia
wife is from
today,
Colombia. I know
Colombia
very
today,
well.
it's
I know
like
very well.
Paris. In
No,
Colombia, they have
no.
the same devices as we have in Paris.
No, no more. No more.
I
No
was in
more.
Colombia
Finish.
2 months ago.
Yeah,
I
man. I
did 7 cases and I had no concern with the
I
material.
treated in Colombia more than 150 patients in 20 years. Like, I know the situation of Colombia. I know the situation of Venezuela. I know the situation in Mexico, in Peru. It's okay. It's better now in Colombia, of course. It's better in Mexico.
Well, this is
But,
not really the concern and the purpose of the talk.
no,
But, I think that we have to keep in mind that it's better to preserve the parent artery. It's better to reconstruct the parent artery. There is no question. You never know what can happen. But if the procedure is really difficult and heroic, we never forget that the hero is the patient, and the patient sometimes, he is running more risk trying to reconstruct the parent artery than doing a parent vessel occlusion.
Jacques, you are agree with me to a second round of this meeting?
Okay.
¿Por qué
The
no?
Okay,
second
we
round
can
is
debate about the
occlusion
parent
of the
vessel
basilar
occlusion.
artery. Okay?
Okay. Well, no problem.
Whenever you
Boxeo,
want.
boxeo.
Okay.
Hey,
Yeah.
we have a question from a neurosurgical resident from Dominican Republic. He's now training in Russia, and he wants to do an observership at Dr. Murray's hospital, and he'll talk to you about that later. Okay, Sinaris, do you have a comment or question?
Bonsoir, bonsoir, docteur et professeur Jacques Moret. Et
Bonsoir.
je suis Patrick Johnson et je suis haïtien. Je vis maintenant ici à Moscou. Je suis en train de faire une spécialisation en neurochirurgie. Je suis résident. Donc, et j'aimerais vous poser une question. La question, c'est que, pour être plus clair, j'aimerais savoir si on a un patient qui a un problème et après l'inst- après l'installation du stent, qu'est-ce qu'on peut l'installer si on n'a pas la possibilité de l'installation du stent?
J'ai pas très bien compris. Un problème une fois le stent mis en
No.
place?
S'il n'a pas la possibilité
Il n'y a pas la possibilité.
de mettre un stent, quelle est l'autre solution? Il a dit, le professeur Moret. Test
L'autre
occlusion.
solution, oui, il y a deux
Anatomie.
problèmes. Il y a 2 problèmes. Mettre des coils dans un anévrisme géant ou géant partiellement thrombosé ne guérit jamais l'anévrisme. S'il n'y a pas la possibilité de mettre un stent, il faut essayer l'occlusion du vaisseau porteur, analyser les circuits collatéraux potentiels. I'm answering in French, is it okay? I'm sorry.
That's okay.
It's okay.
Et essayer de voir si on peut traiter le patient en occluant l'artère porteuse. Si l'occlusion de l'artère porteuse n'est pas possible, à ce moment-là, il faut envisager un bypass chirurgical, mais le coût financier du bypass chirurgical, à mon avis, est plus élevé que celui de mettre un flow diverter.
Merci beaucoup.
Okay.
Le problème,
Bien.
c'est que parfois, les assurances remboursent un acte chirurgical qui est fait depuis plusieurs années et ne remboursent pas un matériel plus ou moins nouveau pour des raisons que j'ignore.
Okay.
Thank
Okay,
you.
Luis. Luis.
Yes.
Okay,
No,
¿qué,
no,
qué quiere hacer, Luis?
yo creo que está bien. Esta
Concluyo.
primera, I think it's okay. This first,
Oh,
concludes?
sí, me alegra mucho porque
and I like
yeah, la manera de
to
tu
grow
idea.
with discussion because Jacques Moret is not only the best, is the best to discuss.
Yeah,
It's the
but
best to discuss, and this is important. It's not the oui, no, ça va. No, discuss.
sí, es
Thank you.
bueno.
Okay,
On blame
Fernando.
plataforma de interacción, a good interaction platform to have commenting while you're presenting. You know, you comment on Dr. Murray and he comments on during your presentation. It brings out more possibilities.
I need to work better on Zoom because I'm used to work with Team, but I'm not used to work with Zoom.
Yeah, it
Good
takes a
training.
while.
Good
Yeah.
training.
Yeah,
Good training.
Sonatas wants to get your email address. Do you mind if I give it to him? He wants
Okay.
to come. He wants to come to your hospital to do an observership.
Yeah, I want it.
I want to conclude, Professor Ruiz.
No, yo me
Yes.
voy a descansar ya. I stop.
I will conclude this round table of neurointerventional radiology. I want to extend my